Good morning, everybody, and welcome all of you to today's edition of the academic cover brought to you by the Academic Subcommittee of the GMOA. Today, we have with us an energetic and young individual to take us through the topic of management of anaphylaxis. Namely, he is Dr. Senitha Liyanage, Consultant Emergency Physician at the ETU of Colombo South Teaching Hospital and the incumbent president of the Sri Lanka College of Emergency Physicians. Briefly about Dr. Senitha, he graduated from the Colombo Medical Faculty with honors, followed by 12 years of experience in critical care, including ICU, anesthesia, and emergency medicine. Obtained the MD in emergency medicine in 2016 as a member of the first batch in Sri Lanka to do so, and followed it by obtaining his MRCEM, member of the Royal College of Emergency Medicine, UK. Apart from that, he also holds postgraduate diplomas in critical care medicine, disaster management, as well as the certificate for competency in anesthesia. He is an internationally accredited instructor in hospital preparedness for emergencies and is also the Assistant Secretary of the College of Palliative Medicine of Sri Lanka. Without further ado, let's begin today's program. Just to remind all of you that the chat box will be open. You can send in your messages and clarify any doubt from Dr. Senitha while the lecture is going on. Over to you, Dr. Senitha.
Thanks, Dr. Raju, for your kind introduction and also for arranging the very timely, important lecture on or talk on anaphylaxis, because all the health staff is much aware the anaphylaxis has come into play in our hospitals bit more relatively compared to the previous days. So in this 1 hour, the first 20 to 30 minutes, we'll discuss the acute management of the anaphylaxis, because anaphylaxis is a vast area. Today we highlight only the acute management but not the long-term management. So we'll discuss the theory part and then followed by bit of cases, how we do it in more practically. At the end of this talk, we'll discuss bit of questions and clarifications what we are having. If you have any questions or clarification, please drop a text message in the chat box. We'll discuss everything. The anaphylaxis is quite important. Why is that? It is appearing suddenly with carrying bit of high rate of mortality unless we manage accordingly. The diagnosis in anaphylaxis is mainly the clinical measure. There's no significant investigation. So anyone can diagnose the anaphylaxis if you know the thing. And if you manage correctly, the outcome also much favorable. And we need only IV fluids and the adrenaline to the management. So in this lecture, we'll see what is anaphylaxis, what is the immediate actions we are going to do, and some special instances. Then we'll see the cases and disposition and how to prevent anaphylaxis. That's also important. The anaphylaxis. We'll see what is the allergy and the anaphylaxis is. We all know the allergy is overreaction of our immune response to a potentially harmless substances. When it's become overwhelmed, generalized, rapidly evolving, and involving multisystemic that we call as anaphylaxis. That is due to profound release of histamine and serotonin from basophils and the mast cells. According to our medical school life, we classified hypersensitivity into 4 types. Anaphylaxis come to type 1 IgE mediated, which onset within 1 hour of the exposure. The diagnosis criteria, because we have realized the diagnosis or the identifying of the anaphylaxis is the challenging thing in our clinical setup. When you go to the literature, there are mainly 2 criteria to diagnose the anaphylaxis. The first thing is acute onset of the skin manifestations or the mucosal manifestations. It can be either one of these 3. that is angioedema, or the facial flushing, or the typical urticarial rash. We all are much more confident on diagnosis allergies with the presence of the urticarial rash. And also, not only that, to become anaphylaxis, there should be one of respiratory compromise or cardiovascular compromise or severe gastrointestinal compromise. So those are the first criteria of the diagnosis of the anaphylaxis. And the second criteria, that is a bit of critical part, because there's no typical skin involvement. There is acute onset with the hypotension or laryngeal edema or the bronchospasms, one of the factors with the history of allergic exposure. That is the most common in hospital setup, because we are giving most of the IV administration of the medications. There's a full-blown exposure of a huge load of anaphylactoid substances into the bloodstream. So therefore, we don't see much skin manifestations in anaphylaxis. It is secondary to IV medications. Therefore, make sure in the absence of the typical skin involvement, still you can get the anaphylaxis, though it is less than 20%, but it is possible. With that background, we'll go to the signs and the symptoms. Mainly the signs and symptoms of anaphylaxis is due to the pathophysiology. So we all know when the allergic substances come into touch, the body thinks that is from the skin contamination. So therefore, they do generalized vasodilatation for the cutaneous systems. Then increased blood flow, which lead to swelling and the warmth and the redness, and increased capillary permeability that leads to hives, and the release of the chemicals that can cause the itching. The same thing happens in respiratory symptoms, starting from the tip of the nose to the alveoli, that increase the blood supply to the respiratory system, and also increase the swelling of the mucosa that give rise to cough, wheezing, shortness of breath, chest tightness, chest pain, and throat tightness, all due to the edema and the limitation of the airway. And next thing is the gastrointestinal system. The body tries to expel whatever the possible allergen from the alimentary tract. How they doing? That increase the bowel movement. So patient complaining of the cramps or the stomach pain due to increased bowel movement, and also they want to expel from either end. So then patient develop nausea, vomiting, and the diarrhea. The cardiovascular and neurological complications are the signs and symptoms due to the secondary effect. That because of the generalized vasodilatation that reduce the cardiac filling, and then they drop the blood pressure. And reduce the blood pressure, then what's happening? Inadequate cerebral blood supply, the patient feel anxiety, fainting, dizziness, lightheadedness, shock, and loss of consciousness at the end. Then we can see what are the trigger factors. When it comes to triggers, we all know anything can cause allergy, anything can cause anaphylaxis. The most common trigger factors are the food and the insect stings and the drugs. We commonly use any kind of medication. The less common triggers are a huge list. I'm not going to each and everything because of the time constraints. And the timing of anaphylaxis, that depend on the substance and the route that we are taking. The oral medications, food we take by mouth, onset will be ranging from 30 minutes to several hours, but commonly we can see within 1 or 2 hours of injection. In contrast, any parenteral input such as bee stings or any other insect stings, or injected medications that include radio contrast and sometimes rarely in vaccines also, they get entire dose of allergic substance into the bloodstream. So therefore they develop the anaphylaxis reaction within 5 minutes to 30 minutes. It's quite short from the time of exposure, and the load and the signs and symptoms also much profound comparing to the oral intake. Then we'll go for immediate action. What we can do if anaphylaxis occurs. We all know the anaphylaxis is not confined to the hospital setting. That happened in the pre-hospital. Even today, before I'm coming to the lecture, I manage an anaphylaxis patient who come to my emergency department from the community following ingestion of unknown food substance, because he don't know what is the food which caused this anaphylaxis. The first thing is the positioning. Why I am telling that? Wherever the poor person is, we can do proper positioning to prevent the fatal outcome. Even we analyzing the patients that who had very bad outcome, we know the positioning is the main issue. You don't need anything to do the proper position. Anyone in the community do the proper positioning. So studies has shown the fatality can occur within minutes if the patient stand or walks or sits suddenly. That means any postural drop or the sudden change of the position or the posture is give rise to fatal outcome. And therefore, make sure the patient is not walking or standing even if they appear to be recovered from the anaphylaxis. So therefore, always use the stretcher, trolley bed or the wheelchair to move the patient from the bed to the trolley and then to the washroom or to the ambulance or transfer from the different departments. And then we'll see what are the safe positions to keep the anaphylaxis patients. It can be supine position, recovery position, propped up position or the holding the patient flat. We all know when you keep the patient supine, we have very good venous blood return, because anaphylaxis occurs due to profound vasodilatation, and because of the increased vasculature volume, the heart won't get good venous return. When the patient is lying supine, they get good venous return and then minimize the complications. The recovery position, or we call left lateral position, we usually use for any patient who is unconscious associated with vomiting, that is to protect the airway. And pregnant ladies, we always keep the inner lateral position because we know the gravid uterus will compromise the blood return by aortocaval compression. So therefore, all the patients who are pregnant or unconscious or threatened to airway, if we are unattended at the patient reviewing, we keep them on a recovery position to protect their airway. And always we keep the patient propped up, especially when the patient has respiratory symptoms. We all know any patient can get bronchial edema or shortness of breath. If we propped up, then they are improve the ventilation. And though I mentioned it is propped up position, the patient should not seated on a chair. So therefore, we prop up them on the couch or the patient bed. And always we monitor it closely, and immediately if the patient becoming reduced level of consciousness, we should make them onto the supine position from the propped up position to maintain the blood pressure. If the patient is an infant or a small child, I know they are not comfortable on staying on the bed, so the parent can hold them on a flat position, but make sure they are not carrying them in upright position or over the shoulder. That is the positioning of the patient. Wherever the patient is, we can easily do to minimize the fatal outcome. And in the pre-hospital level, what we can do, if you think you are a beloved one or your relation or the neighbor who got anaphylaxis at the community, first thing, make sure you are removing of the allergen and the position correctly, as I mentioned before. And sometimes patients who are vulnerable to anaphylaxis might carry the adrenaline self-injector. So you can use it, or patient knows how to use it. Just as I mentioned in the top photograph, we are holding it against the outer mid thigh and inject even over the clothes, and make sure there's no any object intervene between the skin and the cloth, and make sure the adequate depth of injection. So if you're using the adrenaline injector, that all nicely made to serve this the purpose. And make sure we are calling 1990, the suicide ambulance. All the people carry ambulances having adrenaline, and after discussing with the doctors who are on call for the suicide, the EMTs are able to giving adrenaline infusion immediately and transfer the patient to hospital immediately. And if the patient is unresponsive, make sure you are starting CPR early to minimize the fatal outcome. You can repeat the adrenaline after first minute if needed and can repeat each and every 5 to 15 minutes accordingly. Then we'll move to the patient to the hospital. What you can do in the hospital? Always we are starting from the triage. We know if the patient is unconscious or cardiac arrest or high threat to the airway, we take them as category 1. If any patients of hypoxia, shortness of breath and hypotensive, otherwise not life-threatening, we are taking the category 2. And second concept is removal of allergen. If the patient has some bee stings, we can take the bee stings out, and if the patient is on IV infusions, we can stop them, and removal of the further allergic exposure. And third thing is the positioning I mentioned and described in previous slides. Then the adrenaline, that is the life-saving medications which all of are using for anaphylaxis. We use 1 in 1000, that is the same strength that comes in originally in the ampule, and route is IM. Always it's IM, and make sure we are giving it to intramuscular adrenaline injection to the outer middle third of the thigh, nowhere else, because this is the only place which have reasonable amount of blood supply to absorb whatever the adrenaline that we are giving. We use a 1 cc syringe to give the adrenaline, and make sure we use the blue needle, that is the 23 gauge needle, not the original 25 or 26 needle which come for insulin, because insulin we are giving subcut, but adrenaline we are giving IM. That 26 needle is not in adequate length to go through your subcut tissue. So therefore, we always use blue needle or the black needle to give IM injections with adrenaline. For adult, we give 0.5 ml dose of undiluted adrenaline. For pediatric, that is 0.01 ml per kilogram. You can repeat each and every 5 to 15 minutes. We'll discuss a bit more on the pediatric dosing. You can see the chart. I know the chart is okay, but in real emergency, that is not much practical to go through all the charts. But you can place this chart, so anyone is any doubt, you can refer the age and the weight and the correct amount of the dosing. But it is not that difficult to recall what is the adrenaline dose in an emergency. We are giving dose of 0.1 ml of per kilogram. If you think the body weight is 10 kilograms, the dose should be 0.1 ml. We all know the 1 cc syringe is calibrated to 0 to 100. That means 0.1 ml is 10 units of adrenaline for 10 kilograms. It's quite easy. If you take the body weight in kilograms, it's equal number of units, that is adrenaline. So if you take the body weight of 23 kilograms, it's simply calculated as 0.23 ml, that means 23 units in 1 cc syringe. So therefore, it's quite easy. Take the body weight in kilograms, the same amount as a unit in 1 cc syringe of IM adrenaline. The maximum dose is 0.5 ml. Though the body weight comes as 60 of the person, don't give 0.6, always give maximum of 0.5. Next thing is the assessment of the airway. We always check for angioedema. As I mentioned here, you can see the swelling of the lips, tongue and periocular areas, and always we talk to the patient to assess the periglottic swelling. And we always consider early intubation if we think this angioedema is worsening more easily or so quickly, because if it's full-blown angioedema, we are unable to intubate because of the airway closure. And each and every patient, we always use supplemental oxygenation, preferably by the non-rebreathing mask at 15 liters of minute flow rate. The circulation, the utmost important, because we all know profound vasodilatation lead to relative redistribution of the vascular volume. We need huge amount of refilling. So therefore, we use 2 wide bore cannulae. If it's quite difficult, we can go the IO access, but make sure that we are giving good amount of IM adrenaline regularly, correct doses that will increase the blood pressure and then the more visibility of the veins. So therefore, IM adrenaline first before the cannula will improve the blood pressure, thus increasing the ease of cannulation. If the patient is hypotensive, we can have to use 1 to 2 liters of normal saline. That means 2 to 4 bottles of normal saline. Sometimes it goes up to 7 liters. We'll discuss why it is that. In children, we always give 20 ml per kilogram bolus and we will repeat it if needed. In normotensive patients, we use, if it is adult, we use 125 ml per hour to minimize the loss of intravasculature. And disability, we assess once the blood pressure is improving, and always expose the body to check any skin manifestations of urticaria rash or the flushings. Now we'll discuss a bit on the fluid therapy. As I mentioned previously, there's a massive and rapid fluid shift. The research has shown there are up to 35% of intravascular volume move into extravascular space, roughly in total of 2 to 2.5 liters of fluid movement. Therefore, we need large amount of crystalloids. We can use normal saline or the Hartmann. If you use the normal saline, there's a bit of risk of hypochloremic metabolic acidosis. In the Hartmann, sometimes they get metabolic alkalosis. So, no harm of using interchangeably either normal saline or Hartmann. And make sure dextrose is not a suitable fluid to resuscitate the patient, because that carries only water and the dextrose. So dextrose will be metabolized and all the water will dissipate from the vasculature into the intracellular. So it is not a suitable thing to use for fluid therapy. And the colloid, there's no survival benefit using colloids, though they are remaining in the vasculature, and that is costly and not freely available, and also colloids have their own side effects. So therefore, it is not recommended to use colloids in anaphylaxis. So we are only using normal saline or the Hartmann. Next thing, why we are using the adrenaline? So adrenaline, we know there's alpha-1 adrenergic effect and beta-1 and the beta-2. From the alpha-1, they increase vasoconstriction, thus increase the vascular resistance, and that improve the blood pressure. And also that helps to reduce the mucosal edema and minimize the airway narrowing. And also that having positive inotropic and the chronotropic effect on the heart, that leading to increased heart rate as well as the increased blood pressure. Apart from that, that has increased bronchodilation effect, and also there is a decreased release of mediators from the mast cells and the basophils. That is the pathophysiology underlying for the anaphylaxis. What are the other medications we are using? We always reflexively using the steroid and the promethazine if the anaphylaxis comes, but that does not relieve any respiratory compromise, no effect to the cardiovascular issues, and do not inhibit mediator release from mast cells and basophils. So therefore, each of these ones are not a substitute for adrenaline, but we can use for symptomatic control. Here I mentioned the antihistamines only for symptomatic control. We commonly using the promethazine. That is the first generation H2 receptor blockers that can cause drowsiness, and then we are having a bit of doubt whether the patient is drowsiness due to promethazine or worsening of the allergic response. In other countries, they use only the cetirizine as an IV. They don't ever use the promethazine because it's quite associated with drowsiness. And next thing is a H2 receptor blocker like famotidine. Yes, we can use famotidine. That will having synergistic effect if you're using with the H1 receptor blockers. So always if you're using famotidine, use with the H1 receptor blockers. That all medications not substitute for adrenaline. I am emphasizing again and again. The bronchodilators, it is adjunct to adrenaline. We can use it on severe shortness of breath. Next thing is a glucocorticoids. We discuss glucocorticoids a bit later also. that do not relieve initial signs and symptoms, and it might prevent the biphasic or protracted reactions. We'll discuss what are the biphasic reactions later on. And in 2020 systemic review that failed to find evidence for this effect. So therefore, the use of glucocorticoids is always not recommended in the first line. The first line is only the adrenaline and IV fluids. This is the nightmare of the emergency physicians or any physician, the refractory anaphylaxis. Refractory anaphylaxis is a persistent anaphylaxis after appropriate dosing of adrenaline and fluid boluses. Still, patient is failed to improve even after adrenaline infusion. That kind of patients, they need immediate ICU admission. There is no published data on optimum management of the refractory anaphylaxis. So no one knows what is the exact management, but only the supportive care with IV fluids and continuous of the adrenaline. And then we'll see a bit of special instances, mainly in pregnancy. We all get bit of panic if you are treating for pregnant patients. There's no changes of the management in pregnancy. It is adrenaline, that's same as for non-pregnant female, same dose, same route, and everything is same, apart from we are keeping in the left lateral position. When it comes to the infants, the dose is same as the pediatric dose formula, and we need adrenaline. Sometimes that cause hypertension and tachycardia, bit is persisting rather than the normal child. So don't worry, that is due to adrenaline, not because of the persisting anaphylaxis. Now we'll practice some cases. If you have any doubt on the cases, please drop the message in the chat box. We can discuss at the end. We'll move to case number 1. All these cases are real cases actually. So this is 35-year-old male patient presented to the emergency department at 2 o'clock in the morning. Actually, he was going home from a dinner party and he wondered whether he had some seafood. Then our management to check whether it's allergy or the anaphylaxis and do we need to give adrenaline for this patient. So we're going to our management. First we do the triage. The patient is complaining of faintness, he is otherwise conscious, is category 2, and we take the patient to the resusc bed. What is the best position for this patient? Because there's no much shortness of breath, we kept the patient in supine position. Then we'll go for the initial stabilization. We'll assess the airway, breathing, circulation. So airway was patent, lungs were clear, but anyway we given the oxygen via the face mask. On assessing the circulation, pulse rate was 125, bit of tachycardic, blood pressure dropped to 90/60, and capillary refill time was slightly prolonged due to poor skin perfusion. According to the criteria, his acute onset hypotension with possible allergic exposure, that is anaphylaxis, according to the criteria 2. Then the management will give IM adrenaline 0.5 ml or to outer mid-thigh using 1 cc syringe and 23 gauge needle, IV access and normal saline 1 liter bolus. Then we'll reassess the patient. Always reassess, reassess and reassess, and we can repeat adrenaline and saline if needed. Then we can consider your other medications like glucocorticoids or antihistamines if you think it is beneficial, and you keep the patient in emergency department and then transfer to the ward according to their improvement. And you have to plan the long-term management. I'm not discussing long-term management here due to time constraints. And the case number 2. This is 25-year-old female patient. He was on treatment for oral antibiotics for cellulitis, which presented with sudden onset facial swelling, wheezing and shortness of breath 1 hour following the medicines. And then, because of the shortness of breath and he is conscious otherwise, we mark them as category 2 and taken to the resusc bed. Because of the shortness of breath, I'll keep the patient position propped up rather than supine, because that helps for the ease of breathing. And initial stabilization, we check for the airway. Airway was patent but mild degree of angioedema with mild lip swelling. When auscultating the lungs, they show widespread bronchi, so we use oxygen-driven nebulization. When we are nebulizing the patient in acute condition, make sure we are using the oxygen-driven nebulization. This is the oxygen-driven nebulization, it's just same as normal nebulization. Instead of we are connecting the tube to the nebulizer machine, we connect it to the oxygen cylinder. Via the regulator, we open the oxygen speed to 5 liters per minute flow rate. That oxygen flow will nicely nebulize the content in the nebulization canister that prevent hypoxia during the nebulization. And when you nebulize, make sure the canister is filled with 5 ml of total volume with the salbutamol, ipratropium and normal saline. If you are talking salbutamol, you take 5 milligrams, that means 1 ml most of the time. Ipratropium, 500 micrograms, that is again 1 ml, that means 2 ml by the salbutamol and the ipratropium in total, and rest up to 5 ml we are putting 3 ml of normal saline. The total volume is 5 ml. If you don't have either salbutamol or ipratropium, you can put 1 ml of available solution plus 4 ml of normal saline. That make total volume of 5 ml. That will give the nebulization over roughly 5 to 8 minutes. Then, when you are assessing the circulation of this girl, the pulse rate was 130, he is tachycardic, blood pressure is 100 by 60, marginally low, capillary refill time is 2 seconds, that is not prolonged. But according to the criteria, patient is having acute onset angioedema, the skin manifestation with the bronchospasms. So therefore, it is criteria number 1 is fulfilling for anaphylaxis. So therefore, we use IM adrenaline 0.5 ml. And always we use IV access and saline 1 liter bolus. And always we use reassess again and repeat adrenaline and saline if needed. Here the patient has widespread bronchi and the wheezing on the both lungs. So therefore assess how the bronchi improvement with our management of nebulization and the adrenaline. If the bronchi are persisting, you can nebulize with adrenaline also. That also reduce mucosal edema and increase the reduce the resistance. And sometimes we might need to go for management pathway of the acute severe asthma if the wheezing is not get reversed. And you can start glucocorticoids and antihistamines if needed. And once stabilized, we'll admit the patient to the ward for observation, and also management of the cellulitis review, because we can't use the antibiotic which she was given. So we have to change to another antibiotic if needed, if the cellulitis is still persisting, and plan the long-term management. The next thing, case number 3. Another patient who is a 42-year-old male patient presented to the emergency department following gastroenteritis for 3 days duration. He always also complained of faintness for 1 day duration, and he denies any exposure to allergen. So how do you manage this patient? Again, because of the faintness, we'll categorize as category 2 and put to the resusc bed. So we position the patient, propped up position, and initial stabilization. We know the airway is patent, lungs are clear. Anyway, we started oxygen via the face mask, and then circulation, pulse rate of 110, blood pressure was 100 by 60, and capillary refill time of prolonged of more than 3 seconds. When we come to criteria, it is not an acute onset and associated with shock grade 1, no allergies, so it is not an anaphylaxis. So patient came with prolonged gastroenteritis, possible fainting due to hypovolemic shock. So no need of adrenaline. It is not an allergic or not an anaphylaxis, because we always able to judge by clinically which patient is anaphylaxis. Otherwise, all patients of collapse we might treat it with adrenaline thinking of anaphylaxis. So we give the IV saline bolus and reassess and repeat saline, and we started medication for acute gastroenteritis and admit to the ward for observation. And we go for the next patient, the case number 4. It's a 28-year-old female patient with menorrhagia presented with symptomatic anemia. So we have started blood transfusion because hemoglobin was quite low, and she developed fever and itching. So this patient was in the ward actually. Next thing, are we going to do the triage? Because patient is already in ward. Yes, of course. The triaging is the sorting of the patient and providing needed equipment, needed attention and correct amount of staff. So therefore, even in the ward settings, we do triage. How we do triage? We take the resuscitation trolley to the patient and the multipara monitor and improve the patient's monitoring and treating capacity wherever the patient is. So triaging is optimizing and giving the appropriate time, appropriate person, appropriate equipment to a sickest patient. Next thing, the decontamination comes here. That means removal of the blood packet and the blood giving set from the cannula, but keep the same cannula in, and we'll keep the patient position in the supine position. And then initial stabilization, the airway was patent, though having mild angioedema. Lungs were clear. The pulse rate was 92, which is on his normal rate almost. Blood pressure was 100/70. That is slightly in the lower range, but that is compatible with her normal rate because of the low hemoglobin level. And capillary refill time is more than 2 seconds. On exposure, there's an urticaria rash and the fever. So we come to the criteria. Is the acute onset, urticaria rash with blood pressure. We wonder whether low or at the normal level. So we are in doubt whether to give adrenaline or not. But because of the urticaria rash and blood pressure anyway is towards lower side, no harm of giving 1 dose of adrenaline. That won't kill the patient, but that will prevent exacerbation. So therefore, don't get scared to give adrenaline IM. Even you doubt and almost fulfilling the criteria, though it's not 100% fulfilling, will give adrenaline. And make sure the patient was almost normal stensive. So we'll use the normal saline 150 ml per hour through the saline. And we need glucocorticoids, antihistamine, and also once stabilized, get acute patient transfer to the acute cubicle and continue the observation. We have to inform the blood bank, send the blood pack sample as well as patient blood sample to the blood bank to do the repeat analysis. And we have to move the patient to the acute cubicle. The 6 hours later, again she developed urticaria rash without any exposure. And there also again relapse of mild angioedema and dizziness. Why it is that? We call this as biphasic reaction. Any patient who got anaphylaxis, there is a tendency to get a biphasic reaction. That means recurrence of anaphylactic symptoms soon after the initial response. That get only about 5% of the time. So therefore don't worry, not each and every person get the biphasic reaction following anaphylaxis, but 5% is getting. So we don't know which patient will get it, and it can occur even after 24 hours of the initial episode. The good thing is it is usually less severe than the initial episode. Therefore, we have to keep an eye on all the anaphylaxis patients before getting discharged them, and always What are the possible risk factors for biphasic reactions? First thing is the delaying administration of the adrenaline. The second is low response to adrenaline, and also any patient who needed repeated dose of adrenaline are a bit of high risk for develop biphasic reactions. And any patient who need lots and lots of IV fluids, that patients also need biphasic reactions, because these all possible risk factors are enumerated into more high dose of anaphylactoid exposure. So management is same as the management of the anaphylaxis and need to watchful waiting to detect it. That is biphasic reactions. Then we'll move to case number 5. Case number 5 is a 60-year-old female patient currently on IV antibiotics for against cellulitis and develops sudden collapse in the ward, and 5 minutes after the second dose of IV antibiotics. How we are going to manage this patient who has sudden collapse? The management, because the patient is collapsed, unconscious, category 1, so we put into the emergency trolley. That means we take the resusc trolley or the emergency cart to the patient's bed. We don't move the patient to the acute area because we drag emergency trolley very sooner to the patient. Because if you move the patient to the acute bed, it takes some time. So therefore, it's easily we can take the crash cart to the patient place. And position, we keep the patient supine position and we quickly assess the airway, breathing and circulation. So airway is not patent because patient is collapsed. So we do the triple maneuver, head tilt, chin lift or the jaw thrust to open the airway, and we put the oropharyngeal airway to maintain. And patients having labored breathing, we start ambu ventilation. Pulse was not palpable, blood pressure was undetected, so very prolonged capillary fill time. So it is a cardiac arrest. So we activate adult life support guidelines and start CPR. So the criteria is acute onset, hypotension, allergic exposure, it is anaphylaxis, and patient at the moment cardiac arrest secondary to anaphylaxis. So therefore, what is the adrenaline? So don't worry, we following the ALS algorithm. There's 1 in 10,000, 10 ml every 5 minutes and flush with normal saline. So therefore, here in any patients who arrest cardiac arrest following anaphylaxis, so whatever the causes, we never change the plan of management. That is ALS algorithm always. We don't deviate for any other depending on the cause. And we send IV normal saline 1 liter bolus, reassess, repeat adrenaline and saline if needed. After he got restoration of spontaneous circulation, we need IVI adrenaline, that is 0.04 to 0.4 microgram kilogram per minute, and we titrate the rate and the dose of the adrenaline according to the blood pressure of the patient. And we can give other adjunct medications, and this patient need to be intubated, ventilated and ICU care, and followed by the long-term management. And the final case is 18-year-old female patient, known patient with seafood allergy, presented to the emergency department with urticarial rash and mild shortness of breath. On assessment, the patient was stable, so therefore we label it as category 3 patient on triage, and we taken to the acute bed rather than the resusc bed. Because of mainly patient is having shortness of breath, we keep the patient propped up position, and airway was patent, lungs were clear, respiratory is all fine, and circulation pulse rate was 80, blood pressure is stable 115/70, capillary refill time also normal. So therefore, there's an acute onset, urticarial rash with the allergic exposure, but there's no cardiovascular compromise, no bronchial compromise, no GIT issues, so only for fluid allergy. So this patient, no need of adrenaline because it is quite stable. But anyway, because of the allergic reaction, we start IV normal saline 125 ml per hour, and we decide to give glucocorticoids and antihistamines. Then next option, which glucocorticoids we are going to give. We have two options, the prednisolone versus hydrocortisone. Both are synthetic glucocorticoids. Onset of action of each prednisolone and hydrocortisone is 4 to 5 hours after administration. Though we give IV hydrocortisone, it never starts action at the time of administration. So either you give oral prednisolone or IV hydrocortisone, the onset of action is 4 to 5. So there is no benefit over giving IV hydrocortisone versus oral prednisolone when comparing to each two medication. And both medicines 100% bioavailability, and both have not proven its effectiveness in the treatment of anaphylaxis according to 2020 guideline and the literature survey. But both medications help to stabilize of mast cells to reduce biphasic reaction. That is the rationale. Still we are using steroids. In normal practice, we prefer IV hydrocortisone over oral prednisolone if the patient is finding difficulty of swallowing. That means shortness of breath or angioedema. Patient might not able to swallow 12 tablets of prednisolone. And also if the patient is in shock, even though swallowing, the reduced splanchnic circulation might reduce the absorption. So therefore, if the blood pressure is low or any airway compromise, we use hydrocortisone IV compared to the oral prednisolone. If any other instances, we can surely administer oral prednisolone for any patient of anaphylaxis. Right. From that, we'll move to the disposition. If the patient is having severe anaphylaxis, uncontrolled asthma, slow response to adrenaline, or need a repeated dose of IV fluids and adrenaline, he need to be admitted for 24 hours to see the outcome. And prior to discharge, make sure you mention detailed diagnosis card, what is the causative agent, what degree of severity of the allergic reaction, and always mention discharge instructions, discharge medications, and ensure the patient can get access to emergency medical services once the patient goes home. And always arrange the follow-up at clinic visits, and ideally anaphylaxis patients should get the adrenaline auto-injector. That is quite costly and produce short life or the shelf life, but still it's beneficial because it is life-saving. Investigations in anaphylaxis. So anaphylaxis is primarily a clinical diagnosis. So you don't need any sort of investigations to confirm it. But we can do histamine level and serum tryptase in a doubtful cases. If the patient presented with hypotension and we wonder whether it is allergic or not, if you doubt that, to confirm that, we can do serum tryptase level. It is not available in the government sector. We had to go for private laboratory, quite expensive. That takes roughly 19,000 rupees. When you are taking the serum tryptase, we have to take 1 hour, 6 hours and 24 hours to compare the amount of allergic reaction, and we have serum separate and stored at 20 degrees of Celsius. So if it is value comes less than 1 nanogram per ml, that is normal. For true anaphylaxis, the level should be more than 15 nanograms per milliliter. Other than the tryptase level, the RAS testing and CAP testing are other two common methods. We are not describing each in detail. This is the skin or allergic panel testing we are using to detect or diagnose the anaphylaxis and not the anaphylactoid reactions. To refer the patient to the skin testing, there should be 4 to 5 weeks after the initial anaphylaxis reaction. That is, patient should be regenerate the IgE which is used. And also, we should omit antihistamines from the last 5 days, otherwise we don't get good reaction. we have to test all the drugs which was given for the event to check which drug is causing anaphylaxis if this happened to second to IV medication, and saline we use as a negative control and histamine you as the positive control. And then the most important thing, how to mitigate the anaphylaxis. That is the most important part. Sometimes we miss one or two things which lead to anaphylaxis, which we encountered most of our cases in our country. We should clearly document in the BHT, drug chart and the diagnosis card about the allergic history. Please use red pen and clear font mention that minimize unnecessarily accidental giving allergic medications. And we use IV medications only if needed, because we know comparing to the oral medications, IV medications give rise to anaphylaxis rather than allergic reaction. We use the correct dose and correct dilution and the correct rate of administration. Those are very crucial. And always we use, because of we have very poor resource setting, sometimes we use same syringe to give one or two medications, and sometimes we have seen they mix one or two medications each other and giving in the same time. So therefore make sure we avoid mixing with each other medication. We don't know which medicine mix can cause crystallization. Next thing is a ST. We used to do ST for all antibiotics before we go giving, not all but most. Is it safe always? If ST is positive, that means yes, we can't give that medication, high risk of anaphylaxis. If ST negative, can we give without any problem? No, that all depends the way that we are doing the ST. Most of the time, we are doing ST in a wrong technique. So therefore, if the ST become negative, don't give it and without observing, because still they can give the anaphylaxis reaction. Always observe minimum of 20 minutes after IV medication. Always keep your emergency trolley loaded, checked and ready to move, and IV emergency trolley can move without any obstacle to the patient bed. That is the most important thing, because almost all wards and units have the emergency trolley, but they are not in moving condition, or because of the chairs and narrow bed space, they can't take to the patient. So make sure your unit and the ward have a fully filled and checked emergency trolley in a moving condition to right to the bed end. And next thing is IM adrenaline pack. Each and IV trolley, no harm of keeping IM adrenaline pack, but it should be clearly labeled. It is not for IV, it is for IM. And that can administer till emergency trolley reach the patient cubicle. And always suspect anaphylaxis and IM adrenaline 1.5 ml for each and every patient with anaphylaxis to the outer mid thigh. So, any questions, Rajiv, at the moment? If you have any questions, please drop to the question chat box.
Yes, if you have any questions, please, it's the time to shoot in your questions. Since we are waiting for some questions, I was going through the lecture. I think looking at the things that's happening, I think a lot of doctors and a lot of the health staff has some fear of using adrenaline. Adrenaline is, they have some sort of thing about adrenaline to use it. So Dr. Senitha, why don't you give some confidence to our audience about adrenaline and how safe it is and how it can be used in the IM route, and not to fear about adrenaline. If you can give a small...
Yes, Rajiv. Yeah, we always see when we give adrenaline IV route, that can cause huge tachycardia, arrhythmia and blood pressure fluctuations. But it is quite safe if you are giving IM and small dose like 0.5 ml. So please don't hesitate to give it. If you are suspecting the patient is having low blood pressure, whether it is anaphylaxis or not, don't worry, you can give 0.5 ml IM to the mid-thigh out aspect. That never kills the patient. Sometimes it might help you to improve the blood pressure transiently. Till that, with that you can easily give the cannula and give the IV fluids and then reassess the patient. In the periphery settings specifically, please don't get hesitate to give IM adrenaline, because actually it is injected by the general public actually. So in other countries, when the anaphylaxis come to hospital, before they discharge with the 2 pens of adrenaline auto injectors. So the advice what you are giving to the anaphylaxis patients is, if you develop any symptom of anaphylaxis, the first thing, get the adrenaline injector self-administered up to your left or right thigh on the outer middle aspect, then call the ambulance. So that kind of safe if you're giving IM, but don't give IV, but IM is quite safe. It's not a killer, it's a lifesaver.
Yes, thank you, Dr. Senitha, for clearing that doubt and instilling confidence in our doctors to use IM adrenaline appropriately and without fear. So,
So in the sum up of my presentation, I would like to emphasize on mitigation actions after anaphylaxis. That means safe administration precautions, and then always suspect anaphylaxis and IM adrenaline 1 in 1005 0.5 ml to outer mid-thigh and IV fluids. And our motto should be, no one should die from anaphylaxis in a hospital settings. Thank you very much.
Thank you very much, Dr. Senitha. And I think, I hope the audience, all of you who listening, refreshed your knowledge on anaphylaxis, what it is, how to manage, and got some confidence in managing such patients in your clinical practice. So that's a wrap up of things here today from the GMO office with the lecture, and we hope to see you again soon with a timely topic and at the next academic hour, brought to you by the academic subcommittee of the GMOA. Thank you.